And hello, that's right. I'm back. And BIteSized Learning is back. So if you don't know me, I'm Dr. Mike Sevilla. I'm from Salem, Ohio. And we have conversations here on BIteSized Learning. You can get more information at ohioafp.org. We have a whole kind of season of programming there with great topics, great guests. But tonight's topic, actually, it's an array of topics. I'm really looking forward to this conversation. Obviously, we want to talk about family medicine. We're going to talk about medical education. We're going to be talking a little about family physicians in the media. Maybe a little bit about COVID, a little bit about everything. So let me just quickly introduce our guest before we bring her on. Dr. Lou Edje is Associate Dean of Graduate Medical Education at the University of Cincinnati College of Medicine. She is board certified family physician and fellow of the American Academy of Family Physicians. Dr. Edje holds dual appointments as a professor in the Department of Medical Education and Department of Family Medicine and Community Medicine. She was also named OAFP's Family Physician of the Year in 2012. And we would love to welcome Dr. Edje to the program. So thank you for being here, Dr. Edje.
Thank you for having me, Mike. I'm just really looking forward to this.
We'll just kind of dive into things. We have a great array of topics, not a lot of time, and I'm going to hit you just with a really difficult question to start out. Why family medicine? You work, you talk with a lot of residents and medical students, and you work in medical education. Why family medicine?
You know what? It was the 4 C's that got me into family medicine in the first place and have kept me going. So comprehensive, continuous, coordinated, and first contact. And when I think about comprehensive, I think Larry Bauer said it the best. He had a tagline at the bottom of his email that family medicine is rocket science. And it really is. It really gives us a chance to see a patient in one context and then be able to see them in other contexts as well. So for example, 15 years ago, I had a woman who walked in, she's about 24, with a shoulder injury. And so I was working up her shoulder injury, and she was essentially on my musculoskeletal stage from that standpoint, context-wise. And while I was doing my exam, I found some axillary freckles. And so that sent me down the pathway of looking for cafe au lait spots. And she ended up getting worked up for neurofibromatosis. But it's that variety from the comprehensive side that really sort of keeps me involved. The other thing is continuous. And of course, foundational for our specialty are relationships. And I really believe that the types of relationships we have are life-saving. Granted, it's at a different speed than some of our other colleagues, but I think that there's such a trust that gets developed between your patients that they're able to divulge information that they probably wouldn't ordinarily be comfortable bringing forward. It also means that you're involved in some really exciting times in their lives, traveling with them through their highs and lows. I know everyone probably has some wonderful stories, but one of them, one year I ended up being invited to a 50-year birthday party and a 50-year wedding anniversary in the same year. And then the 2 other C's, coordinated care. I think that us as family physicians really have an obligation and really a duty to go ahead and extend that foundation of trust our patients have in us to our specialist colleagues around us. And so when we're able to refer a patient and say, listen, I would go to this person for my own care, I'd send my patients there, that is wonderful. And then the last C, of course, is first contact. And so having an undifferentiated problem presenting in a patient really for me is an intellectual challenge that I really welcome. And, being able to find that 1 millimeter black, mole on the front of their leg that ends up being a melanoma that would have taken them in 5 years. It's very satisfying to be able to do that kind of thing. So those are the 4 C's as to why I got involved, and they really still hold true. I can add a couple in there as well.
Oh, no, we probably will throughout our conversation
yes.
here. I love talking with family physicians about, why they do what they do and how they found their way. And it all kind of recharges me. And when I get around family physicians, which we haven't had a lot of because of everything that's been going on, it's just great to kind of hear people's why. And I know we'll have that more in our conversation. So Dr. Edje, tell us a little bit, maybe give us a little bit of background about you. I know you're everywhere. We'll get into your media and all that stuff, but let's kind of set the table for us. Like, where did you grow up and how did you find your way to college and the medical school? And give us a little bit of that, of your story.
Yeah, so I was born a Hawkeye. I was born in Iowa. My father is an agronomist, so does crop production and agriculture, and he was out there getting his PhD. And then he got stationed in Malawi, South Central Africa. So we moved
Wow.
when I was 11 months old, and I went to British boarding schools. I was a shy kid there. He did his sabbatical then in South America, so we moved to Colombia for a year.
Really?
Yes, indeed,
Wow.
and learned a little bit of Spanish at that point, and then came
Nice.
back here for a year of high school, and then when I was 16, went to Michigan State for physiology. And so the natural segue after you learn how the body works is, you either teach it, you do research in it, or you learn how it doesn't work and how to fix it. And so that sort of led me into medicine. And all the docs that I sort of really wanted to emulate were docs who had a broad base of really great skills. And so that's why family medicine.
Wow. Wow. Like in medical school, is that something that you were drawn to right away, or was that during your medical school experience you just kind of bounce around and have different ideas of, hey, I could do this as a specialty or that as a specialty?
You know what? I enjoyed all my rotations, and I was not ready to give any one of them up yet. And so I still wanted to see derm. I still wanted to, set, do casting. I still wanted to do all these types of things. And I wasn't done seeing my last cardiology patient. So that was one thing that sort of family medicine was the place for me. Absolutely.
And then you went to residency. Where'd you go to residency? And then what happened after residency?
So residency was at Toledo Hospital. I actually was at Michigan for med school, and the residency actually came up, brought up a bucket of pig's feet between my first and second year of med school, and showed us how
Wow.
to do vertical mattress stitching and
Nice.
all of that good stuff, and it was wonderful. And I had not really thought about interviewing in Ohio at all. I was a Michigan girl, and interviewed with them, put them first. I loved it. They were a phenomenal program. So I was at the WW Night program, and then stayed and did private practice there, stayed involved with the residency all the way through that, and subsequently went on to become program director at that same residency.
Wow. So what was that path like? You're in practice, you're involved with a residency, and then you just had a little bit of a bite of medical education and you wanted to pursue your career that way? Like, how did that happen?
Well, when I had actually the very first day I stepped into the doctor's lounge after residency, I looked at all the chiefs of staff pictures up there, and I thought there was actually only one woman on the wall out of 100 years of chiefs of staff. And so I thought, you know what, why not me? Why not in 10 years? And so then I started to plot my 10-year path toward that. And that meant getting involved with department leadership. That meant, being an advocate for my co-staff colleagues, and went ahead and pursued that route. And 6 months before the 10-year goal, I ended up being chief of staff, and was just really privileged to be able to advocate for our group of docs. But then I was like 36, right? So I wasn't, I wasn't done. And at that point, the door opened for me to go ahead and be more involved with medical education. So in 2011, I started as program director. In 2014, my mom graduated from her doctorate. Well, she got her doctorate in education. And at that time, sort of this epiphany happened. And I thought, geez, oh, Pete, I practice evidence-based medicine, but what about evidence-based teaching? And so
Right.
I looked for programs that were teaching health professions education, and Michigan had one. So I went back to my alma mater and did it sort of as a competency-based thing in conjunction with being a full-time program director, and got my MHPE.
Wow. Oh man, it's just so how I mean, I know I'm kind of sprinkling all this other stuff. So how does that help you now?
Yeah, so number one, it helped me to understand how medical professionals learn. That's one thing. There's a whole boatload of evidence on how to teach medical professionals, and the whole cadre of literature on that sort of opened up for me, and it just became something that I was very interested in being involved in. Master adaptive learning, for example, which I wrote an article on through this past summer. Just a lot of different things got involved there. And I wanted to go ahead and be able to put that to use. And this job here at Cincinnati opened up, and that was in 2018. And I ended up coming ahead in 2019 and starting just before the pandemic.
Yeah, I mean, how did that? I mean, we've talked about this before. Like how did that route to Cincinnati open up to you? And I know that you talk to residents and students about always being prepared for kind of any kind of job. Can you share a little bit of that story?
Oh, absolutely. So I always tell my residents and fellows to keep their CV, an updated full CV in their email, ready to send. Usually just a short, 100-word third-person bio, also ready to go, so that if that window of opportunity is there, you're ready to go ahead and be available for a space that you're interested in. So this would have been a year after we'd started a brand new program at St. Luke's Hospital that, I was at a conference and one of my mentors from the master's program said, "Hey, Lou, there's a national search for a DIO, which I'll explain later, for this position at Cincinnati." So, I'd accomplished what I wanted to, which was to graduate 1 year of family medicine residence and make sure that this new program was up and running and had great foundation. And they graduated in June, and July 25th, I was at this conference and that happened. And so, 4 or 5 months later, we'd gone through the whole process of interviews and things like that. And I'd come down to Cincy and taken a look at 3 different practices. I'm with a wonderful practice right now. Really appreciate my new partners. So.
Wow. So that decision, I mean, in your head, I mean, what was that kind of on your 5 or 10-year, map, and say, if there's an opportunity like this, I always have to be prepared. Is that something that, I guess as a leader, as a medical professional, you're always kind of, looking to say, hey, that is on kind of my, my checklist or my professional road to success?
Yeah, I think we always have to take a moment and pause on a regular basis and figure out, so whatever, has our direction changed and the things that we want to accomplish. And certainly, I did want to go ahead and use the master's program that I had used, had trained in. And I felt like I could use that a little bit more than I was. So that this really fit my long-term plan. So.
And so how has your job kind of evolved, or how would you describe what your job is now these days?
Yeah, so my job, I like alliteration. So my elevator pitch is number 1, A, for accreditation. So what we do is make sure that the foundation of each of our programs, there are 96 of them with 694 residents and fellows here. And just to make sure that they're actually doing what they should. I think accreditation and making sure that everything's good is really one of our commitments and our obligations to residents. When they match, it's our job to make sure that we are meeting our match obligations. So that's one thing. And I'm fortunate to be able to actually work with the ACG as well on the Family Medicine Review Committee. So I'm on both sides of that. I evaluate programs. We have 732 here in the country, family medicine programs, and there are about 20 of us who go through and over the course of a year evaluate those and assess new programs as well. So very involved with that piece. And then the second A would be advocacy. And I'm thrilled at one of our most recent advocacy pieces. We just got, this was announced on Friday, 401k matching for all the residents and fellows. And for me, this has been a big issue. When I think about residents at the bedside, every single person around that bed, around the patient, was covered for 401k matching except for the residents. And so it's a great way to recruit residents. It's a great way to take care of them. It's a really great way to show that we're invested in them as valuable members of our team. So that's one. Also advocating for PPE and advocacy for extra space if we had to, do social distancing, and for the human resources they need to do well. So making sure that we're recruiting in faculty and staff that are excellent. And then the last A rather is advancement. So making sure that we really have done a really good job of making sure that they can move on to their next space from a foundation that's healthy, from the standpoint of having a network that goes with them, that they have excellent credentials to go with them, that when their future employments asking, what did they do at Cincinnati? We really have a great record of what they did.
My guest is Dr. Lou Edje from the University of Cincinnati. And that kind of bridges into a kind of a bigger topic here. You alluded a little bit about PPE, and I wanted just to talk about, medical education during a pandemic. And I know this is probably obviously nothing that anybody signed up for, but with your new job and how to do that. And I get a lot of questions from people in the community, and also people in medical education, medical students. Can you talk a little bit about how kind of medical education in a pandemic kind of, how it all happened at UC, and how you had to deal with that?
Yeah, so right away, I actually was out of the country right at the beginning of the pandemic. I was in Malaysia doing a presentation and flew back in mid-March. And at that point in time, just really realized that we had to go ahead and, number one, decide whether we were going to go into emergency pandemic status, which is an accreditation status by the ACGME that allows us to relax some of the rules around training, so that our residents are still getting the training that they need, but they're also able to be mobilized to deal with surges and to be part of the surge task forces for our institution. And so we had to go ahead and make that decision. That meant that the rules would change. We also had to make sure that we had to have, again, appropriate PPE, that people were socially distanced, that everyone was able to don and doff appropriately, that we could move our in-person learning into virtual format and still get as much of the camaraderie that you get from in-person learning as possible. So those were some of the major pieces that went into play. And of course, the morale and the safety. I still am concerned every day that I wake up about the safety of our residents. And, when the immunizations started to come forward and they were approved, the EUA from Moderna and Pfizer were approved in the beginning in December, we started to notice a significant drop off in the number of our residents who had COVID. So just real delighted and haven't had any lasting illnesses or anything like that with our residents.
And they had to be very much of a challenge because, you have these physicians in training and you're still teaching them. But I would guess you would need, some for workforce to help take care of patients, to help take care of the community. And as an educator, that's probably a really fine line. And I know you just talked about the relaxation of some of the requirements and things. And how was it from your standpoint, like an administrative standpoint, to say, hey, what's our balance here? How do we take care of the community, but still take care of the resident, not only from an education standpoint, but from a physical and mental health standpoint? I mean, that'd be very challenging for you and your team.
Absolutely. And it took a lot of collaboration. We had set up initially a surge task force that consisted of residents, chief residents. It consisted of folks in our GME office, as well as other faculty members. And the key thing we had to do is to make sure that the supervision for the residents was appropriate in all of the locations that they were appropriately oriented to doing additional work in spaces that they had not been in recently. So for example, the internal medicine crew were excellent at going ahead and doing sort of orientation back to the ICU for folks who may not have been in the ICU recently, things like that. We also had to make sure that it was fair and equitable so that we weren't pulling from too many resources over time if we could help it. So just trying to minimize the chance that an individual was away from their normal track of training as much as possible.
And then how are things, like the stress and the mental health aspects? How was that dealt with learners and with residents during that time and even now?
Yeah, so that's always a very big concern. So one of the things that we want to do is always make sure that there are immediate resources available, that they're able to be accessed in a timely fashion. So 24-hour turnaround time if we can, to get you in with a mental health professional. Also to make sure that there's confidentiality around that, and that there are long-term strategies that are put into place to make sure that folks are protected as well. And so, for example, we actually do have a psychologist who actually is going into the workspaces to find out, are there any processes that we can do upstream to prevent some of the stressors that residents and fellows have. And then just a couple of weeks ago, we started a group session with the psychologist so that residents have an opportunity to be in that space. It's offered every Monday from 5 to 6.
And kind of what's been the feedback or what's been the response from the residents, and do they feel like that that their needs are being addressed?
Yes, I think so. And again, a lot of what we've done has been in response to requests for needs. And so that's why we've been trying to make sure that we're addressing those. I think there's frustration across the board from the standpoint of the length of time this pandemic has been going on, some of the resistance to folks getting vaccinated as well really just makes it difficult. This is now a preventable disease. And I think in the beginning when it was, everyone trying to figure out what's going on, it was a little bit different. Now this is something that is preventable for the majority of patients. So just trying to make sure that folks are educated on what they need to do to get the vaccine. Dealing with hesitancy is part of that as well.
Now, Dr. Edje, I know I've heard you and seen you share kind of your personal story, especially when it comes to the vaccine. Can you share that with our audience tonight?
Absolutely. So I had midsummer of 2020, I had lost my stepmother to COVID. It was really sudden. She was very healthy. It was over the course of 8 days and she was gone. And just sort of seeing that, the grief within my family, the great loss, the void that was left there, I knew that we did have a Moderna trial site here at UC Health. We were one of 90 Moderna trial sites. And so that weekend, I got the copy of the full consent form and I did my 3-hour sort of intake and got enrolled. I got randomized. At that time, I didn't know whether it was to the placebo limb or to the Moderna limb. But so that was September 12th for my first shot, and didn't actually know whether Moderna was going to work. Hadn't had a lot of experience with mRNA technology at all, but was just really delighted when the EUA was approved in December. And subsequently in January, on the 6th, I found out that I had an unblinding study and found out that I had received the Moderna shot. And so in the process, though, the American Medical Association had done a brief story and had tweeted that out. And that got picked up by Shepard Smith in the news and then MSNBC, and a slew of other organizations started asking me to go ahead and speak on that. And I think the thing that was propelling me forward really was the fact that being a Black woman and being a physician, I had some skills that I could use to bring some credibility to the conversation with people who look like me, especially knowing the historic uncomfortable truths around vaccine trials and some of the Tuskegee issues and so forth down the line. So it's probably been about 96 or 97 either podcasts or interviews or Zoom calls that I've sort of gone into, or I think I spoke to Girl Scouts and parents with sickle cell nationwide, children's, and it's been a number of different places. But any opportunity that I have to be able to get the message out, the vaccine saved lives, I've been doing.
Yeah, I did want to talk about your media, but you did mention maybe that's why they appealed to you, as a minority, as an African American woman, and I'd like to dive into that a little bit because I know in your advocacy for vaccine hesitancy and and trying to address those, how do you approach? Because I know you love using analogies and you love using things that can relate to people when you're talking to those specific groups that look like you or that look like me. How do you address some of those questions when it comes to specifically vaccine hesitancy?
So I think the mindset has to be there first off, the appropriate mindset. So you have to come to it with respect and with patience. I found that it doesn't just usually take a single conversation. It requires, some sort of foundation of trust, possibly an additional conversation down the line. I also think that we are really uniquely equipped as family physicians to be able to go ahead and take complex science and digest it into analogies and information that patients can utilize for their own decision-making, for the safety and health of their families. So going ahead and using a couple of analogies, I have One that I've used with young women who are concerned about fertility, and for me, that's a situation whereby your DNA is locked in the nucleus, which is like a safety deposit box, and mRNA has absolutely zero access. So you're not going to have a change in your genetic makeup. A fetus is not going to be affected by this adversely. For the concern of, boy, this vaccine was made way too fast, you go into the coronavirus timeline, which is decades, and so I think of the cake analogy. I talk about, if a cake is baked over a course of 20 years, which is what we did to study coronaviruses. We've been doing that for 20 years. It took us only 66 days to determine the genetic makeup of the spike protein. And therefore, I liken that to finding out the flavor of the icing, and we ice the cake. So all we've done in the last 11 to 18 months is ice that cake, but the cake was already baked. So this vaccine has been 20 years in the making, not just 11 months.
Yeah, and I experienced that too, with my patients, is just like having that kind of that one-on-one conversation. And, as I mean, it's just a lot of media just kind of, yelling at each other and see who can have the best kind of gotcha moment, and not really having that conversation like family physicians always do with our patients, as far as, hey, and I have a lot of patients, and I know you do, and a lot of my family physician colleagues, our patients come up and say, "Hey, doc, what do you think about this? I've heard this on the news, and I've heard this on social media, and I'm still glad that we have, that relationship, as you related to before, to talk about this." And I love your use of analogies. That is kind of not my strong suit. I'm going to really steal some of your ideas
Go for it.
and to try to relate that to our patients. And I think it's really come down to the fact it's just going to be, one person at a time, one patient at a time, and to really try to explain this and try to get through all this misinformation out there. And I love your use of analogies, and I'm going to try to see how I can incorporate that in my practice. And I hope the people who are watching this will try to incorporate some things that is relatable to patients, to try to explain a lot of the bad information that's out there.
Mm-hmm. So one other analogy for you that I found helpful. I'm not a Snapchat user, but it actually does help with so Kaiser Family Foundation's data shows that some of our resistant folks are between age 18 and 49. So for that 18 to 24 age group, the Snapchat message actually does seem to work fairly well. And that is regarding side effects. A lot of, concern is around, geez, if I get this vaccine, we don't know how long the side effects are going to be, et cetera. But to be able to go ahead and state that it's like a Snapchat message that stays in your system for long enough, 48 hours typically, for your body to respond and make the appropriate antibodies, so that when it receives, exposure to the actual virus, it's able to mount a response. You can say that the side effects only last for about 48 hours. So it's not going to be something that is like a long COVID situation where, you're dealing with neurological issues and so forth from actually getting exposed to the virus itself.
Exactly. Yeah. So it's just, I mean, it's this whole vaccine hesitancy topic and misinformation, and it's like a whole nother hour that we could speak to try to get through all this so we can properly educate our patients and our communities. Let me kind of talk about media, and because I'm very interested in media. I do a lot of local media here. We didn't have any kind of training in medical school. When MSNBC calls, or and I know this, but I mean, sometimes they call and they say, "Hey, can you be ready in an hour or 2 hours?"
Yes.
or something like that. How do you? And a lot of family doctors are like, "I don't want to do that because I get nervous and I can't know how to prep with that." What do you have any kind of like general tips for family docs as far as trying to maybe even not even live T, but maybe talking to a newspaper or something like that, just to get our message out there?
Yeah, absolutely. I think number one is being prepared and having a message that is worth people listening to. So one of as I mentioned just earlier, I was extremely shy, and the thought of sort of getting up in front of anyone was the scariest thing. In fact, I almost didn't go to medical school because the thought of going into a room with strangers every 15 minutes was
I don't believe that.
No, I'm not even kidding. Ask my mom, ask my sis. Pretty scary thought. But I put myself into those positions where I sort of had to, right? So being involved with AMA and doing testimony, being involved with medical school student council, that kind of thing. But I think with the MSNBC thing, I really wanted to be a useful part of the solution to this pandemic because it really hit my family hard.
Yes.
And so getting the message out was critically important. And I think there are some good things about it. I'll tell you this. Most of the time, let's say MSNBC, Eamon Mohaldin, his producer would call and she'd say, hey, Lou, want you to talk about, vaccines in kids. And so they give you a general topic, which is great. So you kind of narrowed it down. They may even ask you a couple of questions. They may even send an article that they want to talk about and have you respond to. And so, you may have that in the morning, and he would come on at between 3 and 4. So take a look at that. I was always trying to keep up. So you find a resource that is useful. And I think family docs need to be doing that anyway, being master adaptive learners and sort of digesting new information and analyzing it. So Kaiser Family Foundation Vaccine Monitor was a very good go-to for what is the pulse of the nation sort of on what are the demographics on vaccine hesitancy. So I do that every morning. I go to Twitter for 3 minutes of every morning as well, just to check. And so this one day, which really sort of was the scariest moment for this, was I'd already got the questions that they were interested in asking. And I get on screen, and 15 minutes before we were meant to go live, she's like, hey, Lou, we're going to just go ahead and have you forget the questions we sent you earlier today. I want you to look at the segment that's on just before you, and we want you to go ahead and do sort of an instant analysis. And I'm thinking to myself, okay, I'm on live TV.
Exactly right.
I have no idea who's going to say what, and I'm going to be giving analysis. So number one, I have to do something like listen really hard and have a cogent answer. Nevertheless, it was actually President Biden, which is, again, middays when he had sort of mid-afternoon was when he'd come with his announcements and stuff. And he had Dr. Fauci. So the segment was President Biden and Dr. Fauci, and it was split screen with them, and I was coming on next. And I had
you have a hot take on the president and Dr. Fauci. Like, I'd be like freaking out in my head.
Yeah, I was. My heart was sort of pounding out of my cage. But anyway, thinking in themes, thinking in threes, those are always good things to do, take home messages. So I was able to go ahead. I had my iPad out, and I was, lumping comments and so forth, and was able to go ahead and do it. Surprisingly, I was able to go ahead and answer what I needed. They kept on asking me back, so it must have been okay.
Yeah. And I tell family docs, I mean, it's not all about live TV too. And like when we get together with our family physician friends, I mean, we all have stories, and media loves stories. And what I tell my family physician colleagues, don't be anxious about talking to the media. It's just they just want to share your story. They want to share maybe what's going on with you in your practice and in your community, and especially with social media now, people don't even know what's true anymore, and it's very very confusing. And when media reach out to family docs, they need us. They need our stories. They need to know what's really going on. They need to know what we really think about things like vaccine hesitancy, and you have an unfortunate story, but you kind of were able to just say, hey, I'm not going to just be sad about it. I'm going to be proactive about it. This is how I want to respond to this, and this is how I want to share my story. So thank you for doing that, and thank you for sharing your story on media. I mean, it's just we need more family docs out there in the media doing what you're doing.
Thank you. I've got a lot of fabulous colleagues that are doing the same thing. So kudos to everyone around the country who's doing it. I know there are other methods as well. So for example, we had 450 family docs here in South Ohio who went ahead and wrote a letter to the school board saying, listen, we need mandatory masking in schools. And so it wasn't just family docs, it was other physicians who care about it, who have their kids in schools. And then of course, once we got that letter out, and it did make a difference. It actually did change some of the school policies around mandatory masking. But it was a collaboration of physicians, and it generated additional sort of best practices in other states as well. So it's all for the good.
Yeah. Let's talk about your passion for advocacy. When did that start, and have you always felt like you've needed to be an advocate or to give back to the community, like, or was that something ingrained with you when you were growing up? How did that all start?
I don't know. I think early on, I realized that even as a medical student, and this is true for current medical students too, we have an incredible influence that we can have in a patient room, but there's a whole sphere of influence that's outside that patient room. So for me, being involved with organized medicine was critically important. I felt that that was an automatic opportunity to amplify a voice, to get some organization around it. And I honestly fell in love with organized medicine very, very early in my career. And so advocating for Ohio physicians, I do that regularly at the national level. Advocating for family docs, definitely. See a lot of my colleagues at least twice a year doing that as well nationally. And I do that currently as well for the Council of Medical Education for the AMA. And thank you again, OAFP, for being one of my endorsers for that. But I think there are places where you can make a difference and multiply your voice. And anytime I can do that for the good of learners, I'm going to be doing that.
I talk to a lot of family docs all the time, and I know you do too, and obviously, and medical students and residents, and they say, "Hey, Mike, that's for you. That's not really for me. That's not something that's really important to me." When you talk to docs about advocacy, and I know, there's, and we'll talk about wellness and burnout and all that stuff. There's all that kind of stuff that's out there. What's your message to medical students and residents and attendings, about not only being an advocate for your community, but being in organized medicine? Why should they be involved?
Oh, it can definitely amplify amplify your message, but it can also actually help to elevate the quality of your work as well. So for example, as an associate dean of graduate medical education, being an advocate helps me to be a better dean. It also helps me to be able to change policy, which can then allow for a pathway for others to continue to advocate. So, for example, we're writing new family medicine requirements, and if we're able to go ahead and have policy be made that residents and fellows can actually spend time advocating and get credit for advocacy work, that's something I'm doing to advocate for them so that they can advocate for other people and they can learn and be exposed to what it means to be able to make a difference at a national, state, regional level as well.
Yeah, and I remember in Toledo, the residency program being closed down, proposed being closed down, and I know that a lot of groups, including OAFP,
Yes.
and we were really kind of early into social media advocacy and all of that, and that was something obviously that impacted you, but that's something that I've seen, because I have a passion for social media in a positive way, that we can get that message out there to really kind of, I think we really made a difference with that. And there have been
Absolutely.
other residency programs across the country through the years that have been either proposed to be closed down or closed down, and really getting kind of all those family medicine advocates out there to say, hey, if Twitter isn't just a negative place that it is. I mean, there is some positive things that can really happen there. Social media can be used in a positive fashion, and there's a lot of examples about that out there. And I know that a lot of residency programs, and I know a lot of program directors out there, really, some of them or a lot of them are shying away their residents for using it for all the negative reasons. But I know that there's a lot of positive things that can happen, especially in advocacy.
Absolutely. And it can happen in a very short period of time. I think the speed at which Twitter happens is nanoseconds in a lot of situations. And so to the issue of, the advocacy that happened around our program, it was incredibly wonderful to have state and national support from family docs to make sure that we had a new program that was starting. And it was a success. We ended up having, all the residents, almost all of the attendings, all of the patients move into that new space into a newly accredited program. And we got full support. So just very excited for that. And if you think about one family doctor taking care of 2,500 patients at the high end, we can impact communities. And when we do advocacy, we advocate not just for individuals, we advocate for communities, and we can make a huge difference. So, that area graduates 6 residents every single, that particular residency program graduates 6 residents every year. And a lot of them stay in the local area and therefore really are making a difference in the community's health.
My guest is Dr. Lou Edje, who wears many hats at the University of Cincinnati. And I guess our last part of our conversation, I'd like to talk a little bit about, self-care and wellness and how you do all this. And I guess my question to you is, how do you balance all this? Like, how do you do all this work and personal life? And because I see you everywhere and you're doing everything, and I'm really happy with your success. But yeah, how do you try to balance your work and personal life?
So that's a great question. I think one thing that I found has been wonderful advice that I got early on was that 20% of your time should be doing something that you absolutely love that replenishes you. And for me, that is critical to burnout. So, to preventing burnout. So, for example, having advocacy as part of my job, I love advocacy. And so it brings me joy. That prevents burnout. It's also, again, one of the 3 A's as to what I do as an associate dean. So it's ingrained. I get paid to do this too, so that's wonderful. Its balance is something that I have to intentionally pursue for sure. I sketch portraits, graphite on paper. And to do that, I have to make sure that I've got my sketch pad immediately accessible.
Wow.
I have a calligraphy pen and blank note cards in my purse at all times. Again, it's proximity for me. If it's available and prepared, I'm more likely to do it. And one thing I did find during this pandemic is that I like writing poetry, which I did not even realize. But the 2 major pieces that I've done have been generated out of sort of a groundswell of feeling, right? So the first one was published in the Journal of Graduate Medical Education just in June. It's 43 words, and it was inspired by my residents and fellows just before we declared emergency pandemic status at our institution. Wow. I'm going to just read it to you real briefly
Sure.
here.
No, take your time.
Yeah. So it's titled, Your Bravery with the Unseen. Thank you for your bravery each time you badge in, unsure of the unseen. Each time you intubate, unsure of the unseen. Each time you walk into a room, unsure of the unseen. Thank you for your bravery each time your bravery is seen.
Wow. Yeah, it just and I'm fascinated with process too. Is that something that just kind of sat down and said boom, or was it like a progression of several little sessions where you kind of crafted all those words together?
That was sort of a one-time sit down sort of thing. And it was just watching the residents literally badge in and not know what COVID was. I mean, the very beginning, it was just really amazing. They continue to do what they needed to do day in, day out. It was a short time to write that one.
Mm-hmm, mm-hmm. And the calligraphy, was that always kind of an interest, or is that something that kind of fell into your lap and you just started experimenting and say, oh, this is interesting, and then you have your system of having something pretty close to you?
You know what? I taught it to myself in college. Part of getting through college was doing portraits and then writing wedding invitations. So made a little change on that. And then it's just something I always keep handy. If their birthdays at the office, I get to write the name on the outside of the card, that kind of fun thing. So,
and you probably said this already. I mean, how do you advise residents and learners, about the importance of self-care and monitoring for burnout and checking on your colleagues and that type of thing?
Yeah. So again, from the accreditation standpoint, just adhering and making sure each of our programs is really adhering to the no more than 80 hours worked per week, averaged over 4 weeks. That's critical. And definitely 1 day off in 7 where you're absolutely doing nothing that has to do with education here. The other thing is just making sure that they stick to the 20% rule. So really finding something that charges you, and 20% of your time is spent doing that. I think that's been the main thing. Having resources available, as I mentioned before, immediately available. and trying to have role models in our program directors for their wellness as well. It's been hard on everybody, I think, but having role models that care about you, I think, is one of the biggest things.
Yeah, I mean, it's tougher now than it was a year ago, a year and a half ago, and just with everything comes back to COVID, everything comes back to the pandemic, and what we're going through now and what we were going through then, and we just really still have to keep checking on our friends and colleagues and checking with them, and obviously checking in with yourself too, because we all know people and our friends and colleagues who work too much. Maybe I'm part of that, but to check in on them as well. So Dr. Edje, before we close up our conversation tonight, just want to ask you if you have any closing thoughts or anything else that we didn't touch on that you wanted to talk about before we end our conversation tonight.
Yeah, I think 3 things, actually. One, I would say take nothing for granted. I have got 5 bonus years right now going on. I had 5 Mother's Days ago, had 2 prolonged expirations as I was walking across a parking lot, took myself to the ER. We did a D-dimer and it was 4,000, and I had bilateral pulmonary emboli. And so at that point, I was heparinized and got Eliquis and so forth. But that's when I started to realize that every day is a bonus day, and don't take anything for granted. When I look back and I think about the fact that my alma mater had 10,000 applications for 170 medical school slots, I'm grateful to be a family physician. When we think about the 86 minutes of pajama time that we spend with our EHR every night, closing our charts, I think about literally thousands of folks who've tried to become family docs and are not yet. The second thing is personal and professional growth occurs at the edges of our comfort zone. And so dare to go to the edge of your comfort zone and to try and step out and do something new. And then lastly, to be a master adaptive learner, I think that is a critically important thing. Learn best how you learn. And that uncomfortable feeling about not knowing something, pay attention to it, fill that gap. That is called a shown surprise. That's when you are able to actually learn the most and learn the best. And so take full advantage of that. We wrote an article, David Price, who's a colleague of mine out of Colorado, on master adaptive learning for family physicians. So take a peek at that. But whatever stage you are in your career, you have influence just because of who you are. And so take advantage of that and continue to save lives. We do it incrementally as family docs, but it's no less important than the saving of lives that other physicians around us do as well. Thank you for having me.
Thank you for those closing thoughts. Yeah, I love talking to family docs, and just recharges me, reminds me of why I went to medical school in the first place. And thank you for your thoughts tonight, and follow Dr. Edje on Twitter. Lots of great stuff. Our guest tonight has been Dr. Lou Edje, so thank you for being here. And if you want to listen to any kind of our past shows, just go to ohioafp.org. You can get our past programs there. And thank you for joining us for BIteSized Learning tonight. So good night, everybody.